Hello, good afternoon, everybody. My name is Ahmed. I'm co-founder and chief exec of Locums Nest. More importantly, I'm a doctor by trade and a measly respiratory SHO over the weekends, but here in Locums Nest capacity to talk about collaborative working and really how a few trusts that we've been working with have really put the people plan in action to support during not only the first phase of COVID-19, but the second. Before I continue with me today, I've got Hannah and Colleen. Hannah, if you'd like to introduce yourself, please.
Yes, hello, I'm Hannah Farr. I'm Head of Temporary Staffing and E-Rostering at Gloucestershire Hospitals.
Thanks, Hannah. And Colleen?
Hi, I'm Colleen Sherlock. I'm Assistant Director of HR at Ashford and St Peter's Hospitals, lead for recruitment, temporary staffing and payroll.
Perfect. No, thank you both. Sorry, NHS Providers team, can we push on to the next slide, please? Great. So this presentation really is going to focus on the pandemic itself, the NHS's response as a whole, but also breaking down into how 8 trusts who've span across 3 ICSs have worked together, supporting one another in true fashion throughout the pandemic as the virus moved from region to region, how the systems work together in a dynamic way to support, focusing mainly on the workforce, but eventually how that led to patient care. So next slide, please. So throughout this presentation, and we'll focus heavily on a Q&A panel at the end, we'll be looking at what is a digital collaborative bank, really, what do we mean by that and how does it work, how the fill rates across the trusts were affected through the pandemic and through the collaborative working, how doctors returning to the front line were supported in a flexible manner, so those doctors who've kind of unfrozen their license to practice or have come out of retirement, how they were supported to get back on to the wards. And we'll later go into the cross-migration of doctors. A big worry is there a mass exodus from one trust to another, putting a trust at risk, and we'll talk through how those risks are mitigated and what the data has shown. How rate harmonizations occurred between the trusts, and crucially how we've introduced Public Health England data to better forecast workforce demand to support those involved. And lastly, what comes next for the collaborative bank, this one specifically, but other collaboratives across the country, and how they can support over the coming winter, which is inevitably going to be quite difficult. Great. Next slide, please. So very briefly, the Digital Collaborative Bank is the largest and most mature collaborative bank for medics. It's been live for about 2.5 years now. It started off with 2 trusts in Surrey, the Royal Surrey and Ashford and St Peter's, and Colleen is here, thankfully, with us today. That was formed in 2017, and it's grown and matured over time, and now spans across 3 ICSs across the south of the country, with those 8 trusts involved. And Hannah's here representing us from Gloucester. Next slide, please. So one key thing that we found, because collaboration has thrown a lot, and the word has thrown a lot into recent discussions, and it's been really put into the limelight by the people plan itself. And one thing that we kind of strive for more than anything across the group is transparency is key. And there are 2 models. You have one collaborative bank where your staff can only see the shifts at your trust, and then if they want to work elsewhere, they have to go through an agency. But the trust might have collaborated across kind of rate harmonization, etc. The other, which this one is kind of anti-silo thinking driven. So the 8 trusts involved have free movement of doctors between them. We put the N in NHS as national, so it's doctors working together and trusts working together. So a doctor from Trust A can pick up shifts at Trust B, C, D, E, and vice versa. And you get this lovely harmony of movement between trusts. So if a cardiologist in one trust can't work a shift on Sunday because it's fully staffed, they can then pick up a bank shift at a neighboring trust without going through an agency. And what this meant was, if we look at the data since the onset of the pandemic, there are 2 lines there. You've got a grey one, which is the bank fill rate for trusts not operating in collaborative banks. And this is across 20-odd trusts across the country. And you can see the average is between 70 and 80% bank fill rate for doctors. But what's interesting is if you look at the blue line, the line just above, the key thing there is the line is always higher. And so what shows is trusts working collaboratively will have a 5 to 10% higher fill rate than those not working collaboratively. And a few slides later, we'll talk through why that's the case, but also shows that there's no net migration or net loss of doctors from one trust to another. There's cross movement between trusts that are 10 miles away and trusts that are 100 miles away, obviously a bit less so. So next slide, please. So this slide is really interesting, and one thing that we as a group did with the 8 trusts was we wanted to grow the staff bank, and we wanted to make it very, very easy for doctors to return to practice should they come out of retirement or unfreeze their licenses. So what we did was we looked at where the pandemic was through March to June, which geographies were worst affected, and for all those doctors that returned to the front line, there was nearly 300 in the first couple of months that came back through us that wished to join as kind of full-time flexible doctors. And we'd look at which trusts were most affected by COVID, and we would guide them to join those staff banks, ensuring that no one medical recruitment team was overstretched. So using the data that we had a lovely overview of which trusts were most in need, and we would push those doctors in the right direction so that they could support the staff on the front line. Next slide, please. So this is a really, really powerful slide. So even though there was a really tough restriction in movement geographically with various lockdowns, we had nearly 1,000 collaborative bank shifts worked across the group. And I'm not going to go through every single cell in this slide, but what you see on the top row, the primary staff bank name, is the parent staff bank of the trust. And then on the y-axis, you've got the trust where the shifts were worked. And this is from March to June, and it really pleases me to say that March till September, nearly every single square that could be colored was colored. And this shows that there's been movement across from every trust, from every other trust. Not a single trust has lost doctors to a neighboring trust, which is a very common conception that we need to kind of really address. It's a change in culture, change of mentality, one towards transparency. And one key thing here was that since the pandemic, we've had a real tightening on international recruitment for obvious reasons. E-rostering is a massive driver, and rightly so. But what one key thing is, which I think we all believe, is our substantive doctors, nurses, AHPs are all working full out. E-rostering is great for making rosters fairer, but you cannot expect to make people work more than they are already. So the only way to really address this gap between supply and demand is to work together. And I think this slide really shows that there is merit in this open, transparent way of working. Next slide, please. So another question that we get, because the system is open, you know, we are not afraid of that, is did the trust rates of pay increase because they're visible to one another? And the truth was no. Because of the pool of doctors, there's near enough 4,500, 5,000 doctors working across the collaborative. It's a change of mentality. This transparency means that you will get 3, 4, 5, in some cases 20 to 25 doctors applying for the same shift. And the incidence of rate breaches drops dramatically. This is one of our trusts in the collaborative, and before Locums Nest, they had a breach rate of 90+%. Since they've joined the collaborative, that's down to 8% and even lower. So it's this transparent way of working really controls the rates. Next slide, please. And this is a very, very new thing that we've just launched, and we discussed it with the group yesterday, actually. We've developed a COVID-19 dashboard, and what this means for the group is we triangulate data from Public Health England geographically to trust data, so we can really see where there are likely surges to occur. So because we all know, if there's a surge in Surrey, for example, of COVID cases, 5 to 10 days later, you are likely to get an increase in demand across your acute medical units, your emergency departments, and a few days after that, you're likely to get intensive care demand increasing. Now, we triangulate that data with workforce data, and we directly contact the departments and the central staffing teams to say you are likely going to need extra supply of doctors on this date, and the system supports for that. It's almost like an early warning score, not for patients, but for a trust given the pandemic. Next slide, please. So lastly, before we get to the more interesting Q&A panel with Hannah and Colleen, it's what are the key steps of joining the group or even forming your own regional collaborative bank? And we like to keep things simple, but we like to keep things safe. And that's why this group has done so well, and it's grown so quickly over 2 years to what is, you know, really a gold standard way of trusts working together and this kind of anti-silo way of thinking. And the first step was, the pre-employment checks and the harmonization of rates. And by harmonization of rates, that does not mean rates have to equal one another, because there are different pulling factors across London, across Surrey, across Gloucester, across the South Coast. Having the exact same rates doesn't need to happen, because there are other reasons and other factors that take into place. What we did work on was we tried to agree on policies of when to escalate rates, the magnitude of rate escalations, when to do them, but crucially having that open channel of communication every 1 to 2 months between the group about imminent winter pressures or other pressures, to make sure that there are no massive discrepancies. So in the past, there would have been a discrepancy of £20 per hour for consultants. That's gone down to 5-10, and hence we're at this very nice status quo of kind of cross migration between trusts. The next thing, the pre-employment checks, and you'd be amazed at how similar these are, although there are some minor differences and some fire safety and some manual handling checks, but the core NHS pre-employment checks are the same. So there's an agreement through the MOU, the Memorandum of Understanding, which highlights these, how frequently you do DBS checks, how frequently do you do the various other pre-employment checks, and just to ensure that there's a safe standard of doctor that's cross-working between. The next thing is the deployment, and very happy for either me or somebody on the panel to talk through the implementation and that element. But the key thing there is iterative improvement. So we have every 1 to 2 months a group meeting where feedback is discussed and new features and functionalities and best practices are shared between trusts, so that as a group, we have this really nice transparent way of one trust doing something in a really good way is shared across the others, rather than trying to reinvent the wheel from square one. At the end of the day, it's patient safety that's paramount. But that's me done. The key bit really for me is the kind of Q&A and the panel. I think Colleen and Hannah have a lot more to say than I do, but we welcome any questions at all. So next slide, please. Thank you. And if we can move to the Q&A, so I don't know if we can bring up our faces for the group, please. Great. Okay. Well, I can see a few questions have come in already, actually. So from Chris Hobson, you briefly referred to the difference between trusts that are 10 miles away from each other versus trusts that are 100 miles away from each other. Is there a maximum distance over which this does or doesn't work, or efficacy starts dropping? Colleen or Hannah, I've got some data I can answer that too, but would either of you like to answer that? Sorry, Colleen, you're on mute.
Sorry, yeah, I'm happy to. So we definitely see more cross cover between our closer trusts, but we're delighted to see our doctors working further away. I think it's we know certainly with junior doctors when they're on rotation, they don't necessarily the organisation they're at isn't necessarily the closest one to their home address. So I think there's no issue with them travelling for a shift, and we know that doctors in particular will travel distance for a shift if it's the right shift for them. So it hasn't really been an issue that's impacted on us. I definitely see the higher crossover with neighbours, but we're happy to have anywhere really.
Great, thank you, Colleen. So yeah, just to support that, of course, the majority of cross cover happens with the trusts that are closer together, but the furthest trusts away are probably Gloucester or Dorset to North Middlesex, and even then, since the onset of the pandemic, there have been in the dozens of shifts that are cross covered, and those are dozens of shifts that either would have gone to agency or would have gone unfilled, given the difficulties in staffing at the moment. So the key point for us is there is no risk to it. Even if there was a trust in the northeast of the country who wish to join, even if only a handful of doctors cross covered between trusts, there's nothing lost. You just benefit in that sense. But I'll go to the next question, which has come from Scotty Gregory from Dorset Health. It appears this is only functioning in acute trusts. Are there any plans to extend this into mental health and community trusts? And I think, guys, can I take this one? So yes, so of the 30 plus trusts who are with locums at the moment, I'd say there are about half a dozen to a dozen of them which are mental health trusts, and we're actually running the process of forming a a mental health collaborative, which will be nationwide, and in that sense, a separate one, given there are separate nuances and specialisms that are needed with mental health versus the acutes and different ways of building it. So very happy to kind of tell you more about that, Scotty, outside of this. But that project is well underway and very exciting. Great. I've got another question from outside this, and it's, what happens if I lose all my doctors? Colleen, would you be happy to answer that, I guess?
Yeah, sure. So that was certainly a concern for us at the start when we went into the collaborative bank. We knew it was a risk, that what if all of our doctors go and work in another trust? But there's absolutely nothing to stop them doing that now anyway, without the collaborative, because they can do that through an agency. And that was in developing the collaborative in conjunction with Locums Nest. Our thinking was, what do doctors get out of an agency? They get the opportunity to see shifts all across the country, in any other trust, different rates, the right specialties, the right times, dates for them. And that's what we wanted to be able to offer, but to offer those opportunities as bank. Rather than through an agency. So we knew it was a risk, but we thought it would work, and we took it, and it didn't materialize. It wasn't a risk, it wasn't a problem. It just, our fill increased because it was better being able to offer the doctors a choice of shifts. You know, if we didn't have a shift in the right specialty or at the right grade or time, there might be one with a collaborative trust. So it has the benefit of enabling the doctor to still work within bank, within the NHS, to do a bank shift by expanding it. And it definitely, it worked, didn't it? We saw the evidence of our increase in bank fill.
Thank you very much, Colleen. Another question that's come through. It's, do you need to have an e-roster in place before forming a collaborative bank? I guess, Hannah, maybe best for you, given your role.
Yeah, definitely. So short answer is no. We don't have a e-rostering solution in place for our juniors at the moment. And I think Colleen and I were discussing before this that we're looking at ways and solutions for that at the present. So no, you don't need an e-rostering in place. We manually put our shifts onto Locums Nest, and it's a very quick and easy way of publishing our shifts.
Great, thank you, Hannah. So a few more questions. I'm rushing in, guys. So from Janet Rosser from the Walton Centre, is the system potentially more effective if the collaborating trusts share similar / the same service lines? Hannah, Colleen, open to either of you on that one.
Yeah, I can jump in. I think so. Because you certainly then have doctors with the same specialty, the same competences who can work across, but doesn't have to be exactly the same. I mean, we've found doctors, juniors who've trained and have got competencies in a number of specialties can fill different specialism gaps. So it works from that way. So you don't have to be completely aligned, but I think what you said before, Ahmed, about how acute trusts and different, community or mental health trusts probably does make sense. But there's still crossover there. Yeah, I mean, I just keep thinking it's like, you look at what shifts an agency might have and you pick the ones that suit. So it doesn't really, the more shifts available to doctors, the more that are likely to be picked up.
Perfect, thank you. And then one more question, similar. So from Martin McCann from an NHS Specialist Trust, are the shifts cross-covered for all providers, including mental health and secondary providers? And I can answer that one. Within the collaborative, at the moment, it is acute trusts, some of which have community sites affiliated to them, and those shifts are being filled. Some even have some nursing homes where shifts are being cross-covered via the collaborative. We're building a separate mental health collaborative bank, which will be nationwide, and that project is underway. But there is no reason why you can't have a community trust working with an acute trust. There are a lot of overlaps with general practitioners, general medics, care the elderly physicians as well, where they can cross-cover. So thank you for that. So next one is, how long did it take for you to get up and running with the collaborative after going live with the system? And Hannah, maybe over to you, given Gloucester went live not too long ago, actually.
Yeah, it was a very quick process actually. So we joined Locum's Nest, and within about 6 weeks or so, we were joining the collaborative. So it was a really easy process. And as Ahmed has already said, we are joining the monthly meetings, and we regularly meet as a group to discuss topics.
Thanks, Hannah. And I guess Colleen, it's a slightly different story when we first started working together. You're happy to tell the group.
Yeah, certainly. So Royal Surrey had already been working with you using Locum's Nest for a few months, hadn't they? I think as part of a pilot, and then we joined in May 2017, and we worked closely because they're our neighbours anyway. And I think we sort of asked the question: oh, would it be possible to make our shifts available to Royal Surrey doctors and Royal Surrey shifts available to our doctors? And that was it. The collaborative was formed, really, wasn't it? And Locum's Nest, you were able to help facilitate that. And then it was as simple as that, just make our shifts available. And we put the MOU in place so that we knew we wouldn't need to, doctors would not need to join the banks. So you just join, the doctors just join one bank and one trust bank and stay on that, or their substantive host employer. And it just grew from there. So yeah, it really was quite simple.
Great. No, thank you both. So we've had a barrage of questions, which is always nice. I'll try and answer 2 of them because I feel like they're addressed to me, and then I'll pass on the rest. So from Jane Slatter, we've got: do you share if doctors registered are under any trust performance process? And we've had a few instances of this, not many by any means, but as you would expect with thousands of shifts going through. And this is all down to within the Collaborative Bank, we have the regular forums where we discuss things, but also we have a regular medical director kind of triage session where they bring up any areas of concern with doctors. So any concerns are raised between the group, and within each doctor's passport, within the digital passport, there is a note section which is passed across in a GDPR compliant way for other trusts to see that if other doctors are being looked at to be approved or rejected by shifts. Great. And then next one is: how can Locum's Nest support continuity of care? Can it support trust in having block bookings to fill rota gaps or vacant posts, in addition to short notice requirements? Thank you, Gemma. This is from West Sussex. I can take this one as this is a very technical one. Yes, absolutely. So you can either post kind of ad hoc sporadic shifts, sickness, etc., on the platform, but you can also post longer term shifts, and you can do block bookings, or you can pre-match doctors well into the future. I think we have shifts booked all the way up into September 2021, which is great. And for us, we're not an agency. That we started this to save the NHS money, make life better for people. So if a doctor comes and works at your trust and loves the trust because it's a great trust and they feel like the training is great and they feel respected and looked after, and they do a few more bank shifts, and then they sign a substantive contract, and then they become a full-time doctor with you, we're not an agency. There are no kind of transactional fees or introductory fees. That's perfect. That's exactly what we want to do. So hope that answers that question. And then if we move down to the next question, how has this affected agency usage and fees, and is there a plan to look at a similar model for other work/staff groups? I'll put this out to either of you, actually, Colleen or Hannah.
Yeah, I can jump in. So within the first financial year of using Locum's Nest, we'd reduced our agency spend by 2 million. And we didn't, our bank was very much internal, very much run by the rota coordinators filling shifts prior to that. So we weren't moving from a bank provider to another bank provider. It was from sort of just done informally to Locum's Nest. But still, that saving, massive reduction, and that was net. So our bank spend, of course, grew, but our agency spend reduced so much. It was an overall saving of 2 million. And it was done in conjunction with cultural change as well, led by our medical director, and that was so important to be able to get buy-in. I think our junior doctors bought into it straight away. They could see the benefit and were really keen to use it. But we also needed our senior medical leaders to buy into it. So so that cultural change really helped, led by our medical director too. But yeah, if that answers the question.
Thank you, Colleen. And a few more coming through. Are staff happier at Slash? Has well-being improved a result of this way of working? Hannah, have you had any contact with staff, with either the doctors or the AHPs involved, or even the temporary staffing team?
Yeah, absolutely. So we went from a place of booking our shifts through Excel spreadsheets and paper timesheets, booking shifts through emails. And what we found was a lot of our locums were becoming frustrated with receiving emails about shifts that they weren't interested in and they didn't qualify for whatever reason. So absolutely, we have seen such an improvement in not only our fill rate, but people are enjoying booking the shifts now, and certainly for our locum team here, you know, we've reduced the amount of timesheets that we have to process paper timesheets by, you know, we're probably 95%. So overall, we've had a very, very positive experience, yes.
Great, thank you, Hannah. Colleen, I would pass it on, but conscious of time and the questions keep flooding in, which is good. Next question from Gemma Leach, West Sussex. Have the Trust found in the collaborative sorry, the questions keep moving. Have the Trust found the collaborative found any benefits to being able to fill posts substantively through doctors coming to work for them through Locums Nest, then taking permanent posts? I'm not sure if are you aware of any, or
Not something we've actually measured, but certainly we have definitely seen an increase in a reduction in our vacancies over the last couple of years. Definitely been an increase in quantity and quality of candidates applying for our junior and our consultant posts. So, you know, I'm sure it's a contributory factor.
Great. Hannah, have you analysed this data yet? I appreciate it's early days.
Yeah, similar to Colleen's answer, I'm sure it's had an impact, but we haven't had the data yet.
Great, thank you both. Gemma, from me, even if there were 100 of them that took permanent posts, the Trust wouldn't have been charged a penny for them for us, because that's not in our ethics as Locums Nest, but can certainly get that data if of interest. Next question from Kevin. Have you seen improvements in patient outcomes or wait times or other performance measures as a result of the use of collaborative banks?
I certainly can answer. We haven't triangulated as such our patient data, but what we have seen is a reduction in our exception reports for junior doctors. So we were seeing quite a number of exception reports coming through, and in the last year or so, they have significantly reduced, and that's been that. So our Guardian of Safe Working is reporting that linked to the reduction in unfilled shifts as well. So, if we've certainly looked at that data and can match that.
Right. Just for us, very quickly on that, Kevin. So we've done a lot of work with the Kent, Surrey and Sussex Academic Health Science Network. They've published a 60-70 page report, and one of the area was care outcomes and how they've been improved. So I think it's much nicer for an independent review of this to be shared. So very happy for the team at our stand to pass that on to you or any colleagues about that, because it's very interesting that the link between not just saving money from agencies, but actually what the continuity of care and how collaborative working benefits to patients at the end of the day. Great, and I've got one more question that's come outside of this. It's how does payroll between the trusts work operationally? So how do doctors get paid?
Shall I jump in? So when we first talked about the collaborative, our biggest aim was to be able to reduce agency, and therefore we needed to make it as easy for doctors to pick up shifts through the collaborative bank as it is for them to work through agency. So that included being able to see all the shifts, which they could see all the shifts that are available to them, and as Hannah said, you know, those that are applicable to them, not just every single shift. But also we were mindful that when people work through an agency, it doesn't matter where they work, they get all of their shifts paid on one pay slip, and usually weekly. So rather than having the doctors making the doctors have to register on every single trust bank that they wanted to work with. They just register or already a substantive employee on one bank of their choosing, and then what we do is all of their shifts come through a report from Locums Nest, either weekly or monthly. We're on weekly pay at the moment, and we just put them through our payroll, and then any of the shifts that are worked by the other trusts, our finance department just recharge the cost and the on costs to the other trusts. So it does create a little bit of additional work, back office work for the finance teams to be charging each other each month for the shifts. But our focus was on making it as simple as possible for the doctors to encourage them to be part of it. So we decided that was a really good an increase in back office work that was well worth doing, and I think that's made a big impact on it. So they just get the one pay slip, either weekly or monthly, and we take care of all the recharging behind the scenes.
Perfect. No, Colleen, Hannah, that we've run out of time, but thank you both very, very much for coming on board and helping answer those questions. And thank you, NHS providers, for giving us the opportunity. Hope to see some of you at our stand, and Colleen, Hannah will catch up soon, no doubt. Thank you.
Thank you.
Thank you.